Hello and welcome to PTA 222, Patient Care Skills. So we're going to be doing, some of these lectures are going to be pre-recorded so that you can have access to the information at home and at your leisure time to review them when you are prepared to, and preferably before the assigned class. So, and then you can go back to it afterwards for review. What I want to do with this first lecture is to start off by reviewing the syllabus for the class so that you understand what's going on. And then when we get into class, you can ask questions if it's not clear as to how things are going to run in this class. We will review the practical exam that you just did in your for your other classes, and we'll do that in class. What I want to discuss today is talking about understanding patient communication skills, and give you an opportunity today to demonstrate the ability to instruct therapeutic exercise. We'll talk about patient interview skills, and then we'll talk about manual therapy considerations today for the cervical and thoracic spine. The rest of the class is designed to really be a lab to where you get to practice the exercises yourself, but then also what's more important is practice teaching another person how to do those exercises, looking for the common mistakes that people make, the compensatory patterns that are commonly used, and learn how to cue your fellow students who are going to act as your future patients, cue them to be able to do the exercises properly. So I'm going to escape from this for a moment. We're going to review the course syllabus. So this class is 22 hours of mostly lab. So like I said, we're going to be having these videos for your use to prepare for the class. When you come into the class, I will answer questions. We will have open discussion about the information that was presented in these videos. And then we will also, then that'll give us more time to actually do the fun stuff, which is really getting down to practicing our palpation skills, practicing our exercise prescription ideas. We'll also be doing case studies in the class as well. So you should read this because everything that you need to know about the course is in the syllabus. So how will I assess you? I'm going to assess you on practical exams, class presentations, critical thinking questions, and SOAP notes. Those are things that I can give you actual grades on. And then I will let you read the learning outcomes. Really, this class is designed to take everything that you're learning in your didactic classes and applying it to where you'll be ready to use it in the clinical setting when you go out to your first clinical rotation, which is PTA 225. So I'll let you read all of those. What I wanted to get to was grading. And so the final practical is going to be basically a SOAP note that you will write for your final practical, the combined practical. So as I graded your SOAP notes for this last lab practical or your combined practical, that was just a pass-fail. That wasn't based on that didn't get graded as you'll have more scrutinizing on this grade on this note, and that will contribute to this course. You will also be doing group presentations. You will have 5 different SOAP notes to write. We will be doing case studies throughout the course, and at the end of one of the last days of the class, we will be doing case studies, and you will be able to get points for those. And then lastly, classroom participation and professional behavior. Now, keep in mind, this also includes any online interactions that we have. So for the online discussion forums, I will be keeping track of your participation in that as well. And keep in mind that the way I grade is I provide the points for the things that I find. And if you don't have it, then there's no points given. I don't deduct points unless you're late for an assignment. So if you're late turning in a SOAP note assignment, then 5 points will get deducted off of that automatically right off the top. So that's the only time I'm going to deduct points, is if something is late. But the rest, usually what happens is if I have a grading rubric, which we'll go over for the SOAP notes, you accumulate the points for the things that you have. And if you don't have the full amount of information that you need, then you won't get the full amount of points. And then here is the rubric for participation. So if you need more information, this is how I evaluate classroom participation as well. So we are going to be starting off with going kind of right in line with what you're learning in ortho. So this first week, you're doing cervical and thoracic, and then I will be covering that. Once I I'm caught up with ortho. Once we get up to the wrist and hand, then we'll go back and do the body parts that you did in your first term, which would be hip and lumbar, knee, and ankle. So I will let you review the rest of this. This is the basically the layout for the class. We will have a guest speaker most likely at some point during the class. So I may have to reorganize or move a couple of items during the class. If that's the case, I'll let you know in advance. But that would be to allow for the guest lecturer. Okay. So like I said, we will review the term one practical together as a group when you get into class. So don't worry about that right now. And what I want to start off with now today is talking about communicating with your patient. So I want you to think for a moment, and you can pause the video and write down before you move on into the slide deck, what are the main forms of communication? So think about those different means of communicating with others, and I want you to write those down. And then I also want you to think about what can you do to ensure your success with patient communication. So when you're thinking about the different forms of communication, I want you to also reflect on how you like to be communicated with, especially if you are in a patient caregiver, care provider, medical care provider situation. What are the things that you appreciate as a patient? And what are the things that you don't appreciate as a patient? Because those ideas can cue you in on how to be a better communicator when you are the care provider, the medical care provider. So you want to know who your audience is. So who is this patient that you're talking to? So you're going to know that by reading the initial evaluation thoroughly. So always go back to the initial evaluation. The primary physical therapist wrote down all kinds of information about this patient. You want to understand what their past medical history is, what their pain history looks like, what their prior level of function was, and what is their current level of function. And that gives you some indication as to how debilitating their current condition is for them. And lastly, you really need to know what your patient's goals are. That's the most important thing you need to know about your patient is what are their goals. So the physical therapist wrote goals down. They should be in alignment with what the patient wants. And I'll give you a clue, it probably has something to do with their prior level of function. Most of us want to get back to our prior level of function. If we've been injured and we can't do the things we want to do, our goal is to get back to our normal life and not have to worry about going to the doctor, not have to worry about going to physical therapy appointments, just go back to how we were functioning before. You want to present yourself favorably. So be confident. Patients who are speaking to a care provider that presents as a confident individual that helps them buy into what has to happen. You want to be professional. So you want to really pay attention to how jokey you are, how much kidding around you do, and you want to make sure you're dressing for your job. Remember, your patient's first impression of you is going to have an impact on how well they listen to you, how much they respect your information that's coming from you. And you want to make sure that you are starting off on the right foot by being professional and like I said, dressing appropriately for your job. I also want you to keep in mind when you are speaking to your patients, utilize pauses. So it's very easy to get nervous and overwhelmed, and your brain's running a million miles a minute, and your mouth can't keep up with the ideas that are coming from your brain. And so, what happens is we tend to fall into the and and okay, and so and like this, and it's very disconcerting to a patient who is looking at you as a professional and really wanting to get professional information from you. But if you're coming back at them with a lot of ums and and like and ums and nos, they're going to lose their confidence in you. It's hard to focus on the information you're providing. So what you want to do is, especially if if you have a problem with those ums and utilize pauses. Speak a little bit slower. Give your brain time to transfer information to the motor component of your jaw and get that information out. And I realize I just said right in the middle of that because I did not get my information to my mouth quick enough. And that little pause, the was reflexive. So it's something that we always have to keep practicing. Okay, proximity with your patient. You do need to be sitting near your patient. And so most of us will be wearing face coverings of some kind. So we should be able to get a little bit closer than 6 feet. So make sure you're near your patient. You want to be able to speak in a inside speaking voice. You don't want to be so close that you would be requiring or that you would be able to whisper necessarily. But some patients do not like it if you have my kind of voice, which is unfortunately loud in almost every situation. So sometimes I've had patients become really uncomfortable with my tendency towards animation and loudness. So that's something I have to be aware of when I am speaking to my patients. So close enough that you can hear each other, maybe not so close that you could, hear a pin drop and have to whisper at each other. Um, you want to be facing your patient and you want to make appropriate amount of eye contact. So you don't want to be staring at your patient's eyeballs the whole time. That is going to make many people, if not all people, extremely uncomfortable. But you also don't want to only be staring at your computer. Most of us are documenting on computer-based systems. So you need to explain to your patient, I'm going to be typing in some of this information if you don't mind, but you do need to understand when to make those pauses and look up at your patient. Sometimes your patient will give you that information. I need you to look at me now. So listen to what they're saying. And if you feel them slowing down and trying to make that connection with you, please remember to look back up at your patient and give them that connection. You want to use your good posture, especially if you're going to be talking about posture later on in your treatment. Try to start off with good posture. Make sure that your facial expressions are appropriate for the situation. Sometimes we are speaking to patients who make us feel exasperated and frustrated and annoyed and irritated. And those are really common and real feelings. It's going to happen, but you have to do your best to try to put that aside and present yourself still with the facial expression that's appropriate for the situation. So you best not be rolling your eyes. Definitely don't do that. But you want to also make sure that you're you, checking your feelings, your internal feelings at the door, and make sure that you're giving this person your undivided attention. The other thing I would give you as a trick when you're talking to your patients is if you go to mirror activities you want them to do, say you're about to do some goniometric measuring of their shoulder flexion, and you're facing them. If I want them to lift up their left arm, I might raise my right arm to directly mirror which arm I want to go up. So I'll say, raise your left arm as I raise my right arm so they can see this is the motion I'm wanting. And if I'm facing them, that's the side that I want them to lift up. It works in most cases. Sometimes patients will be confused by that. But most patients will immediately mirror what you're doing on the mirrored side that you're moving. So there are two videos here that I am not going to play during my presentation here. They are on the handout, the PDF handout. So these are two different videos on motivational interviewing strategies. So I'm going to pause here so that you can open up those videos on YouTube and watch the videos. When you are done with the videos, come back and we will continue with this lecture. So with motivational interviewing, remember the key points are to ask those open-ended questions that try to engage that patient to provide you more information. Remember, you're going to give those affirmations that are authentic and positive. So say they didn't do their home exercise program 3 times a day, but they got to it once a day. You really feel like 3 times a day is going to be a better choice. So, but you don't want to say, oh gosh, I knew it. You didn't do it 3 times a day. This is horrible. You're a bad person. And even if you don't necessarily say it that way, we do have ways of speaking that indicate that would be the take home message from our patient. So definitely give those affirmations of, well, at least you tried. I'm really glad that you tried that. That was good. And I'm hoping that it felt comfortable enough that you could try to make that happen maybe 2 or 3 times a day would be great. I think the more often you do that stretch, the better this is going to feel in the long run. You want to use those reflections. So you want to, when they're talking to you, reflect back the things that they're saying. So that they know that you're getting that information. And you want to definitely use those summaries. So what I'm understanding is These are the things that you're concerned with. So summarize what they have said so that really, really affirms that you have been listening and that you have been taking in that information. And then utilize those change statements as well. So um, make sure that they understand that. And I loved it. I love that idea of getting that patient buy-in. If the patient feels like they have control over their situation and that they're not just listening to you and getting all the information from you, most ideas are received better when the patient feels like they had a part in those decision making, in the decision making. So definitely make sure that they understand they're part of you're a part of their team, but they are the captain of that team. So they need to be driving some of this change as well. So when you're going to prepare yourself for instructing a patient with exercise, for some patients, you got to really be aware of how distracting the environment is. So make sure, especially if you got a new exercise or something that you think is going to be a little bit more complex, try to figure out a way to get in a non-distracting environment if possible. You want to think about functional tasks when selecting exercises. So, if they're having difficulties with household chores, think about what that functional task looks like. And does it require a squat? Maybe squatting is something that this patient is going to need to learn how to do properly in order to facilitate being able to get back to those functional tasks. Maybe it's a particular reach, or that reach really requires some additional trunk rotation in order to make that happen. So you can look at those functional tasks, look at the movement components that are involved in those tasks, because those movement components will direct you to exercise. Is there a movement component that requires increased ankle dorsiflexion? Well, a squat it requires increased ankle dorsiflexion. You have to have ankle dorsiflexion in order to be able to do a good squat. Going downstairs requires a tremendous amount of ankle dorsiflexion. It also requires a lot of eccentric calf strength and eccentric quad strength. So there's some more exercises for you. I have difficulty going downstairs. Okay, well, let's see what that calf strength looks like. Let's look what that knee strength looks like. Can this patient control a short range eccentric load on either one of those muscles? So your exercises are right there in front of you. You just have to be able to pick out those movement components and pick an exercise and pick something that will go and complement that movement component. Demonstrate the proper performance of the exercise. This is why in our lab we're going to be practicing these exercises. Demonstrate what that exercise should look like, and then have the patient model your movements. If it's appropriate or feasible, you can initially guide the patient through the desired movement. So, say they're doing a quadruped activity where they lift a leg up. You might kneel on the floor next to them and help them glide the leg back and lift it to an appropriate height that allows them to lift the leg without the lumbar spine arching. So you can guide them through the movement, give them tactile cues. Have the patient demonstrate the exercise as you supervise and provide feedback. So now they demonstrate the exercise and you provide them that feedback. Oh, wait, don't lift the leg so high. It's making you arch your back too much. Why don't you engage your core muscles just a little bit more? I'm going to put my hand right next to your hip here, right at your side of your belly. This is the muscle here that I want you to tense up and really focus on slowly moving that leg back. Don't let your back arch. I don't want you lifting this leg with your back muscles. So that kind of feedback. Provide specific action-related feedback. So when you did that exercise, I saw your back was arched. So I want you to Squeeze your glutes a little bit harder, tilt your pelvis a little bit more posterior or backwards. Posteriorly, they may not understand what posterior is. So make sure you're using language that they understand. And allow time for your patient to practice and learn the components of the exercise program over several visits. So if they have a series of exercises that they have to do, make sure they have time to practice and learn the components of that program. So don't just expect that they'll have all 8 exercises of this program learn today. Maybe you're only giving them 2 exercises today. Make sure that they understand that before they move on to the next exercise. If you're giving them a program or a group of exercises. Use clear and concise verbal and written directions. And I really like giving people pictures and drawings. I've done many illustrations. I've taken illustrations from other sources, and then I've drawn arrows and circles. I've drawn like a whole new arm just so that they see, I don't want the arm to go this direction. I want it to go that direction. So sometimes you have to get really creative with your art skills to really get them to understand it. I've also had patients who wrote down their own notes while we were talking because that's how they processed information as well. So that might be another avenue. You might ask them, do you want a piece of paper and a pen to write down some of these things? I plan on giving you this information, but if you like to write things down for yourself, that might be another good way for them to learn it. So considerations when you are treating the cervical and thoracic spine. Posture is always going to be a factor in cervical and thoracic spine dysfunction. So always look at their posture. Always look at their alignment when they're sitting, their alignment when they're standing, and then their alignment when they're doing the particular functional tasks that they are having difficulty with. Cervical muscle dysfunction can contribute to headache pain. So our patients who have neck pain, headaches, a history of headaches, a history of jaw pain, TMJ issues. A lot of times those are connected to cervical muscle dysfunction. So if the deep cervical flexors are weak, or the posterior muscles are particularly tight, then you're going to be tending to fall into that forward head posture, which is not a normal alignment for the cervical or jaw or TMJ joints. Thoracic alignment is influenced by the balance between the length and strength of those anterior scapular and shoulder muscles and the posterior muscles. So if the posterior scapular muscles are in a lengthened position, if they're weak, if they if they're overstretched, then the scapula can glide forward. And if you sit there right now and glide your scapulas forward, what tends to happen is the thoracic spine will start to go into an increased kyphosis positioning. Now, most of us, when we do that thoracic kyphosis, we're still going to have our eyes on the horizon. So there is a reflex that keeps our eyes looking where we want them to look. So if we're looking straight ahead and you slouch your upper back, your cervical spine is immediately going to go into extension. So you've got the forward head, cervical excessive cervical extension, and then excessive cervical or thoracic flexion or kyphosis. Breathing patterns will also influence cervical muscle and thoracic muscle function and dysfunction. So our patients who have history of asthma, that may be more upper chest breathers, they can get hypertrophy of their scalenes. That hypertrophy of the scalenes, remember, there's nerve roots that exit through the scalenes. So if the cervical nerve roots are exiting around muscles that are hypertrophied, larger than they normally would be, or inordinately tight, that can restrict the movement and also circulation to those nerve roots. And so over time, those nerve roots can start providing bad information, either through pain, numbness or tingling, and in severe cases can actually affect the motor unit of those nerves and cause weakness. So again, here are some videos that I want you to watch on your own. So you can pause this video in order to watch them, or you can watch them after you're done with this video. So the series over here on the right in purple are from a massage therapist who paints muscles onto her subjects. And what's really cool is I loved the ability to be able to see a muscle in its position on a person. So instead of just looking at your 3D models of what a muscle looks like, and it doesn't look like a person, it looks like a skeleton with a muscle on it, right? When you look at it with on a person, though, it helps you visualize where that origin is, where the insertion is, what happens when that muscle shortens. It pulls the origin insertion and insertion closer to each other. That's what creates movement. So if you know your origin and your insertion, you know now what the movement is that will happen when that muscle contracts. You will also know what movement you need to do to stretch it. So moving the origin and the insertion away from each other and elongating that muscle is your stretch. So it makes more sense. Where are these exercises? Do I need to memorize 500,000 exercises? Well, if I memorize my O's and I's and my muscle action, then I can create exercises based on what those muscles do and what I want. The other wonderful thing I want you to look at is now PhysioU has surface anatomy palpation in their application. So I also want you to look at surface anatomy palpation and palpation for the cervical and thoracic spine in PhysioU. We will be utilizing that information in lab when you come to class. Lastly, I want to talk about posture. So remember, I was telling you that posture is going to affect cervical and thoracic alignment. So if you Google posture, you're going to come up with a lot of information. So, but the common themes that you will see will be terms like neutral spine, head alignment, and scapular positioning. So if you look over here, as this guy here has no lumbar lordosis, quite a bit of thoracic kyphosis and cervical extension. This guy has a little bit of not quite a lordosis, still lots of kyphosis and that cervical extension. Here we're can't see his lumbar spine, but it looks like we're beginning to get some lumbar lordosis, which then looks like it's decreased that kyphosis. The head is still forward here. And then we have what we're saying is our modern man, who is nice and tall. That ear is aligned in alignment with the shoulder. The thoracic spine is no longer has that pronounced kyphosis. The lumbar lordosis we can't see. But then, as you can see, as we've evolved down to our computer, we're basically back to that starting position. No lumbar lordosis, tons of thoracic kyphosis. And because we're tending to look up, there's lots of cervical lordosis here. That forward head posture is happening again. And here is that guy again. Your spine should not look like a C. If most of the spine looks like a C, that means your cervical spine is definitely going to have to do a whiplash reverse up here in order for us to see in front of us. So With our lovely sitting posture, typically we want our bottoms to go all the way to the back of the chair and our lumbar supported. And you see the keyboard is down here at about 90 degrees and the monitor is straight ahead. Really, I think that monitor is a little bit high because our natural gaze is about 30 degrees down from the horizon. So if you think that is straight across, the middle of the screen, we want to be about 30 degrees below that horizon point. And then here's a standing posture from Move You on YouTube. And you can see this goofy grin here. You get the goofy grin when you have good posture. Again, that increased lordosis, the anterior pelvic tilt, feeds into or it's a consequence of having that increased cervical or thoracic kyphosis. So if you correct one, oftentimes the other will also fall into place. But remember, we are also influenced by how tight the anterior scapular muscles are. So if those anterior scapular muscles are really tight, then they're going to pull the scapula forward, increasing the likelihood of thoracic kyphosis. Posture. So, like I said, if you Google posture, you're going to find all kinds of contraptions. So here we have a contraption that will revolutionize your posture. We actually have muscles that do this, and we can use them free of charge. We just have to know which ones need to be strengthened and which ones need to be lengthened in order to improve the likelihood of having better posture. What I normally, I started to allude to earlier, for this is my sitting posture checklist, because most of the people we see are having postural issues because of exactly what I'm doing right now. I'm sitting at a computer. I have my monitor raised to help increase the likelihood that I will have my head in a good alignment. And I have an external keyboard to increase the likelihood that my arms will be in good alignment, that I'm not reaching for anything. I also have to remind myself, sitting all the way to the back of the chair. So what happens over time is if you sit too far away from the back of the chair, you'll actually start looking for support. So you'll start to slouch in order to make contact with the chair. So if you can scoot all the way back, get that anterior pelvic tilt, and then put a little bit of support for that lumbar curve. Not a ton. It doesn't need to be a gigantic pillow. A lot of those lumbar supports just look too big for most people. Once that lumbar curve is supported, though, it's easier for the thoracic spine to sit a little bit more neutral. The ear should be aligned with the AC joint. So if the ear is here's the AC joint and his ear is way over here, right? So we want the ear to be in alignment with the AC joint, the chin level to the ground. And then you can give them a little bit of a cue. Lift up your sternum and squeeze your shoulders back and down. So we'll be going over these exercises in class. So I want you to go through the PowerPoint that is in it's in Moodle. And I want you to look at these exercises and you can start practicing some of them now if you want, but we will be going over these in class. So these exercises here are to facilitate range of motion. These will also facilitate range of motion, and you can see which ones are more contributing to rotation versus side bending versus flexion extension. These are progressions of deep cervical neck flexor strengthening. So we've got our chin tucks, the sitting and prone, chin tucking into a TheraBand. You could even do that quadruped chin tuck, which would be similar to that prone chin tuck. And then the upper cervical rotation with the chin tuck, and then the diaphragmatic breathing. These exercises are geared towards the scapular strengthening. So remember what I was saying is if those posterior scapular muscles are weak, then it's easier for the scapulas to slide, abduct, and slide forward. So oftentimes we are trying to train our patients to get better strength for those scapular stabilizers. You're going to see these again when we talk about the shoulder. Foam roll is a good way for mobilizing the thoracic spine and also, as you can see, mobilizing, increasing flexibility in the shoulders. I've even done abdominal stabilization training on a foam roll because it's a little bit more unstable versus being laying on the floor. So in Moodle on the right before the day one information, there is a functional exercise progression pyramid. I want you to also open that and review it. I want you to keep in mind these principles when you're thinking about the exercises that we're going to review. And I want to think about when we're reviewing these exercises, look at those slides and try to figure out which of those exercises look like they would be beginner exercises. And why do you think they would be considered beginner exercises? I also want you to look back and try to figure out which exercises would be a progression or what looks more advanced. So if we're talking about thoracic mobility, what would be a beginner exercise for thoracic mobility? And if the patient is tolerating that really well and they've been doing it for a couple of visits, how can you progress that? What's going to be more advanced version of that? So I want you to think about that because we will be discussing matching 3 exercises that look like they would be a logical progression. So what it looks easiest if I was working on one particular activity or muscle, what exercise looks easy, which exercise looks like it would be the first progression off of that, and what exercise looks like it would be a third progression off of that. So the easiest to the most difficult, because this is what you're going to be doing in the clinic. If your patient comes back and they've been overdoing it over the weekend, you can't necessarily go back to that original list of exercises and say, well, you're at an 8 out of 10 pain now. You were only at a 4 out of 10 pain last time. Let's do all of these exercises that you did when you were at a 4 out of 10. That's not going to fly well. Your patient is going to hate you, and the primary PT is going to be super irritated that you had the patient do those exercises. You're going to have to pick and choose which exercise looks like they would be able to still tolerate it, given now that they have an 8 out of 10 pain. Is exercise even appropriate now? Maybe you need to revert back to manual therapy techniques or a modality in order to get that pain back under control. So remember, your job is to identify what's going to be appropriate for this person today, and what will make their situation better. If they come back and they're in less pain, then you can probably start working on progressing those exercises. If they come back and they're looking like they've, really irritated things, you may need to regress those exercises that you just progressed. Maybe that's going back to the exercise they did before your progression, or that might be even going a step back even further. And definitely, if your patient is coming in with a substantial change to their status, you need to notify the primary PT. We will look at these case studies in class. We will go over them together. I look forward to seeing you in class. And like I said, we will discuss this presentation and you can ask any questions. So if you have questions from today, definitely write them down and bring them to class. Have a great day.